Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm glad you're here. Each week we take a focused, calm look at new research shaping how we care for critically ill patients. For many of us, staying current is challenging, so the goal here is simple. Provide a quick but meaningful review of the latest data with practical takeaways you can use at the bedside. This week we're covering 3 important pieces. We start with a large randomized trial comparing ketamine and etomidate for rapid sequence intubation, a long-standing debate for emergency and ICU clinicians. Then we move to a chest analysis exploring discordant pleural exudates, a diagnostic blind spot many of us encounter more often than we realize. And finally, we close with the new European Society of Intensive Care Medicine 2025 shock guidelines, a major review capturing consensus shifts in hemodynamic monitoring and resuscitation strategy. As always, this podcast is for educational purposes only and should not replace clinical judgment. Links to all articles are in the description. Let's get started. Published in the New England Journal of Medicine this month, this multi-center randomized trial by Casey and colleagues addresses a question that has hovered over emergency and ICU practice for decades. Does ketamine reduce mortality compared with etomidate when used for induction during rapid sequence intubation? The trial enrolled 2,365 critically ill adults across 14 EDs and ICUs in the United States. Patients were randomized 1-to-1 to receive ketamine at a clinician-selected dose between 1.0 and 2.0 milligrams per kilogram, or etomidate at 0.2 to 0.3 milligrams per kilogram. The design was pragmatic, unblinded, and conducted under exception from consent provisions. Nearly all other aspects of airway management were left to clinician discretion, which reflects real-world practice but also introduces heterogeneity in care. The primary outcome was in-hospital mortality by day 28. Secondary outcomes included cardiovascular collapse during intubation, defined using a strict composite, systolic blood pressure less than 65 millimeters of mercury, new or increased vasopressor requirement, or cardiac arrest within 2 minutes of induction. The results were clear. Mortality by day 28 occurred in 28.1% of patients receiving ketamine and 29.1% of those receiving etomidate. The adjusted risk difference was minus 0.8 percentage points, with a 95% confidence interval from minus 4.5 to 2.9, and a p-value of 0.65. In other words, no evidence of superiority for ketamine. This finding pushes against earlier observational studies suggesting etomidate could worsen outcomes by suppressing adrenal function, effects shown in mechanistic studies to last up to 72 hours. But here, despite those biological concerns, no mortality signal emerged. That aligns with several prior randomized trials, though those earlier studies were smaller. The secondary outcome told a more nuanced story. Cardiovascular collapse occurred more frequently in the ketamine group, 22.1% versus 17.0%, an absolute difference of 5.1 percentage points. Ketamine's hemodynamic profile is often described as catecholamine sparing, but in catecholamine-depleted states, its intrinsic negative inotropy and vasodilatory effects may dominate. This trial's findings are consistent with that physiology. Other exploratory outcomes, lowest systolic pressure, lowest oxygen saturation, intubation success rates, vasopressor use at 24 hours, did not differ meaningfully between groups. Importantly, the trial was powered for mortality, not hemodynamic events, but the cardiovascular collapse finding is clinically relevant. So what do we do with this? From a bedside perspective, the results should temper the assumption that ketamine is inherently safer for hemodynamically unstable patients. In fact, if a patient is already catecholamine depleted, as in septic shock or prolonged ICU illness, ketamine may be more likely to precipitate hypotension. Etomidate still carries its adrenal suppression baggage, but the clinical consequence of that suppression appears smaller than once feared. Clinicians can reasonably choose either agent, but the decision should be individualized. If adrenal axis integrity is a concern, for example, In patients with sepsis not yet receiving steroids, it remains reasonable to avoid or limit etomidate. On the other hand, in profoundly unstable patients with depleted sympathetic reserve, etomidate may remain the more stable agent. Overall, this well-powered trial settles an important debate. Mortality does not differ. Hemodynamic collapse may be more common with ketamine, and induction choice should remain tailored rather than dogmatic. Published in Chest, this retrospective cohort study by Adala and colleagues examines an often overlooked diagnostic scenario: exudative pleural effusions that fail to show concordance between protein and LDH levels. In routine practice, we rely heavily on Light's criteria, but in up to a third of exudates, the protein and LDH signals diverge, one high, one low, creating a gray zone that complicates interpretation. The team analyzed 995 pleural fluid samples collected from a UK tertiary center between 2015 and 2017. After excluding transudates and incomplete records, 715 exudative effusions remained. Among these, 229 cases, or 32%, were discordant. Two phenotypes were defined: protein high, LDH low, and LDH high, protein low. Of the discordant cases, 63% were protein high, LDH low, and 37% were LDH high, protein low. The median age was higher in the discordant cohort, 75 years versus 70 years, suggesting that age-related comorbidities or chronic pleural processes may influence the biochemical pattern. But the more striking finding was the diagnostic distribution. Discordant effusions were significantly more common in certain etiologies and noticeably less common in others. For example, fluid overload-related effusions appeared in 10% of discordant cases versus 2% of concordant cases. ICU-associated effusions also had higher discordance, 9% versus 3%. Benign asbestos-related effusions were more frequent, 14% versus 9%. These patterns held after adjusting for age and sex using multivariable logistic regression. On the other hand, diagnoses typically associated with robust inflammatory processes tended to produce concordant elevations. Pleural infection occurred in 6% of discordant samples versus 16% of concordant. Malignant effusions were 34% of discordant cases versus 42% of concordant. The odds ratios consistently favored these trends. From a physiological standpoint, these findings make sense. Protein reflects permeability and chronicity. LDH reflects cell turnover, inflammation, and metabolic activity. When only one is elevated, the pleural environment may be dominated by a single process, either chronic low-grade exudation without intense inflammation, or high cellular breakdown without proportional protein leakage. The clinical consequence is that relying solely on Light's criteria risks misclassification and misprioritization. A discordant exudate should prompt clinicians to rethink the differential. Fluid overload and ICU-associated effusions, for example, may mimic exudates due to protein or LDH shifts, but require entirely different management strategies. Likewise, some early or indolent malignancies may appear biochemically muted. An important strength of the study is the thorough diagnostic adjudication using multidisciplinary review, incorporating cytology, imaging, biopsy results, and clinical follow-up. This gives confidence that the diagnostic associations are real, not artifact. For everyday practice, the implication is straightforward. When protein and LDH disagree, the sample is telling you something. These effusions form a distinct biological category and should not be dismissed as analytical noise. Clinicians should assess for discordance early, especially in older patients or those with mixed medical comorbidities. In the bigger picture, while Light's criteria remain sensitive, they are blunt tools in an era when many conditions produce borderline or mixed biochemical signals. Discordant exudates highlight the need for refined diagnostic models, possibly integrating pleural fluid cholesterol, NT-proBNP, ADA, or machine learning-based signatures. This study pushes us to be more deliberate and avoid anchoring bias. Discordance should not be overlooked. It shifts the diagnostic landscape and should recalibrate the clinician's initial pathway for workup. Published in Intensive Care Medicine, the new ESICM guidelines on circulatory shock and hemodynamic monitoring represent a major update to the 2014 consensus statement. Led by Monet and colleagues, this document synthesizes decades of work and brings the field closer to a structured, multimodal approach to shock assessment. It includes 50 statements, combining graded recommendations with ungraded good practice statements. The guidelines begin by re-emphasizing that shock is fundamentally a state of inadequate oxygen delivery or utilization. Importantly, hypotension is common but not required for the diagnosis. The focus instead shifts to tissue-level perfusion, the 3 windows clinicians should check early: mental status, urine output, and skin perfusion. Capillary refill time is elevated to a central role. The Society recommends serial capillary refill time assessment, supplemented by skin temperature and modeling evaluation. This aligns with recent trials showing that resuscitation strategies guided by peripheral perfusion can outperform lactate-guided approaches, particularly when lactate remains elevated due to non-hypoxic mechanisms. A major emphasis of the guidelines is on dynamic assessment. Persistent shock after initial fluid resuscitation should prompt evaluation of fluid responsiveness before giving more fluids. The guideline is explicit on this point. Static markers, such as CVP, are no longer viewed as reliable indicators of preload or responsiveness. Instead, the guidelines prefer dynamic variables: passive leg raising, pulse pressure variation, stroke volume variation, and other reversible preload challenges when feasible. This reflects a growing consensus that unnecessary fluids can do more harm than good, particularly when extravascular lung water increases or venous congestion worsens. The recommendations also address hemodynamic monitoring in a layered manner. For patients requiring vasopressors or those not stabilizing after initial therapy, arterial catheter-based blood pressure monitoring is advised. Central venous pressure should still be measured when a central line is present, not for predicting responsiveness, but as part of a broader picture of venous congestion and right-sided pressures. For patients who fail to improve, the guidelines recommend monitoring cardiac output or stroke volume directly, using technologies such as transpulmonary thermodilution, pulmonary artery catheterization, or non-invasive methods depending on context and institutional capability. Echocardiography is elevated to a first-line tool. The guidelines suggest using echo not only to classify shock type, hypovolemic, distributive, cardiogenic, obstructive, but also to track changes during resuscitation and evaluate treatment responses. The group highlights that ventricular phenotypes, particularly right ventricular dysfunction, carry prognostic significance. In real practice, this encourages an early move toward integrated ultrasound-based assessments rather than relying on surrogates or delayed imaging. Another noteworthy update involves microcirculation. While not yet mainstream in many ICUs, techniques assessing sublingual microvascular flow and veno-arterial CO2 differences are recognized as valuable adjuncts for understanding whether macrocirculatory improvements actually translate into perfusion recovery. High veno-arterial CO2 differences or abnormal microvascular flow patterns may signal persistent mismatch between oxygen delivery and utilization, even when blood pressure and cardiac output appear normal. The document also clarifies blood pressure targets, recommending an initial MAP of 65 to 70 millimeters of mercury in septic shock, with consideration for higher targets in patients with chronic hypertension or if perfusion improves at higher pressures. Trauma-related shock is addressed separately, acknowledging the need for permissive hypotension before bleeding control when no traumatic brain injury is present. Taken together, this 2025 shock guidelines emphasize a modern, layered, physiology-first approach. Early bedside markers, dynamic tests, and integrated hemodynamic monitoring replace older static metrics. For clinicians, the message is clear. Shock evaluation must be continuous, multimodal, and individualized. And improving numbers alone is not the same as restoring perfusion. That wraps up this week's review. We looked at a major randomized trial that helped settle the ketamine versus etomidate debate, a chess study highlighting how discordant pleural exudates can reshape our diagnostic reasoning, and the comprehensive ESICM guidelines that redefine how we assess and monitor shock in the ICU. As always, this podcast is here to support your clinical practice, not replace your judgment. If you found this helpful, consider subscribing and sharing it with colleagues who want a quick, reliable way to stay updated. I'll see you next week for more pulmonary and critical care research that matters.